Good morning and welcome. Today we'll be exploring the fascinating journey of cocaine, tracing its roots from the ancient Andean use of the coca leaf to the complex cycles of misuse and public health challenges we face today. This presentation will delve into the cultural origins of cocaine, starting with indigenous practices in the Andes, the isolation of the substance in the 1800s, and how its impact has evolved over time. The image behind me highlights those lush terraced fields where coca plants have been cultivated for centuries, symbolizing the deep historical connection we'll be examining. Let's begin this important discussion. Let's look at the early medical uses of cocaine. Initially, cocaine was primarily valued for its ability to serve as a local anesthetic, especially in surgeries involving ENT or ear, nose, and throat procedures. It provided effective topical pain relief by blocking nerve signals, making it a powerful tool for surgeons before modern anesthetics were developed. On the historical side, cocaine was introduced during what's called the hypodermic era. It was even featured in various patent medicines, widely advertised and sold for different ailments. One notable figure associated with early cocaine experimentation is Sigmund Freud, who initially explored its effects with some enthusiasm. This highlights how cocaine gained popularity in medical and public use before its harmful addictive properties became fully understood. Over time, as the dangers became clear, its use was heavily regulated and curtailed. The image here represents an old Coca-Cola advertisement, reminding us of how cocaine originally played a role in popular products before its risks led to restrictions. This transition marks an important chapter in medical history and drug regulation. Here we have a clear view of cocaine use trends in the US over the past century. Notice how, in the early 1900s, cocaine use was quite high, around 80% in relative terms, reflecting its widespread availability before strict regulations were in place. Moving into the 1930s, we see a sharp decline to about 20%, largely due to new laws and the rise of amphetamines as alternatives. Then in the 1970s, use starts to climb again, reaching around 50%, setting the stage for the dramatic surge in the mid-1980s when cocaine use hit its peak at 100% in this relative scale, coinciding with the crack epidemic. Finally, the 2000s show a significant drop back down to around 40%. This pattern highlights how cocaine use has ebbed and flowed in response to social, legal, and economic factors, giving us insight into the cyclical nature of drug epidemics. Here we see an overview of cocaine use on a global scale, focusing on production areas and consumption patterns. The Andes region is still the primary source of cocaine, while North America and Europe remain the largest markets where the drug is consumed. Looking at the chart, there's a clear gender difference. About two-thirds of cocaine users are male, compared to one-third female. This gap is important to consider when designing intervention programs. Additionally, young adults between 18 and 25 years old are the most frequent users, which emphasizes the need to focus prevention efforts on this age group. It's also worth noting that in recent years, cocaine availability has increased in Europe and Australia, along with the rise of synthetic alternatives that may influence future trends. Understanding these demographic and regional patterns helps us better allocate resources and tailor public health strategies more effectively. Here, we're looking at how cocaine works in the brain at a biochemical level. Cocaine blocks the reuptake of three key neurotransmitters: dopamine, serotonin, and norepinephrine. By preventing their reabsorption, it increases their concentration in the synapse, which leads to strong feelings of pleasure and reinforcement, essentially the euphoria associated with cocaine use. Moving on to pharmacokinetics, cocaine acts very quickly, but the effects don't last long. Users develop tolerance rapidly, meaning they need more to achieve the same high. Something important to note is benzoylecgonine, an inactive metabolite of cocaine that stays in the body for days and can be detected in urine, making it useful for drug testing. Finally, the way cocaine is administered greatly affects how quickly and intensely it acts. Smoking delivers the drug to the brain the fastest, followed by intravenous injection, and lastly snorting, which has a slower onset and less intense peak effects. This difference in routes explains variations in the experience and the potential risks involved. Here we see the 6 primary methods of cocaine administration. First, snorting, where cocaine is inhaled through the nasal membranes, with effects peaking within 10 to 20 minutes and lasting about an hour. Then there's intravenous injection, which delivers cocaine directly into the bloodstream, reaching the brain in under 30 seconds and causing a rapid onset of effects. Smoking crack cocaine is another method. By inhaling the drug through the lungs, it reaches the brain in as little as 7 seconds, producing a very intense and immediate rush. Sublingual use involves placing cocaine under the tongue, allowing quick absorption into the bloodstream, though the exact impact on brain levels varies. Rectal administration provides local anesthesia but carries significant risks, including tissue damage and infection. Lastly, traditional coca chewing produces relatively low blood cocaine levels and is culturally important in some high-altitude regions. Each method differs in how fast the drug acts, its intensity, and the potential health risks involved. Here we see the acute effects of cocaine use, which happen very quickly and change rapidly over a short time. First, right after use, there's an intense euphoria called the rush, which can feel as powerful as a sexual orgasm. This happens within seconds to minutes and is symbolized here with the stopwatch icon. Then comes the peak phase, lasting about 10 to 20 minutes, where the intense euphoria starts to shift into increased energy and excitement. The hourglass icon helps us remember how brief this period is. Finally, within a few hours after the last use, users often experience what's known as the crash, a deep depression or dysphoria that can linger for days. The sad face icon shows the emotional downturn during this phase. This pattern of rapid highs followed by lows leads to quick tolerance development. As a result, users may increase their doses or change their methods of use to smoking or injection to try to maintain that initial rush. The concert image here represents the environment of extended use sessions, often called coke runs, where individuals repeatedly take cocaine to sustain effects despite growing tolerance and increased overdose risk. This slide details the serious respiratory and cardiovascular complications linked to cocaine misuse. Starting with the respiratory system, smoking cocaine can damage the bronchioles and lung tissue, leading to chronic bronchiolitis. This often causes symptoms like wheezing and asthma-like breathing difficulties. Additionally, lung damage can result in pneumothorax, where the lung collapses, and increased susceptibility to infections such as pneumonia. Turning to the cardiovascular effects, cocaine accelerates atherosclerosis, which is the buildup of plaque in arteries. This contributes to coronary artery disease and can lead to myocardial infarction or heart attacks. Cocaine use can also provoke dangerous arrhythmias and, due to spikes in blood pressure, may cause acute aortic dissection, a life-threatening emergency. The primary cardiovascular mechanism involves vasoconstriction, which narrows blood vessels and speeds up plaque accumulation. This combination leads to ischemia, where areas of the heart receive insufficient blood supply, and microinfarcts, causing long-term impairment of heart function and increasing the risk of sudden cardiac death. It's important to distinguish between acute and chronic effects here. Acute events such as coronary spasms cause immediate ischemia, while chronic changes like plaque buildup cause ongoing damage to the heart over time. Finally, drug interactions add to these risks. When cocaine is combined with alcohol, it produces a toxic substance called coca-ethylene, which significantly heightens cardiac risk. If opioids are used concurrently, the chance of overdose and fatality rises even further. Overall, both immediate and lasting physiological changes from cocaine use severely threaten respiratory and cardiovascular health, underscoring the critical dangers of this drug. Cocaine misuse has serious and wide-ranging effects on the brain. One of the primary impacts is a significant reduction in cerebral blood flow, affecting at least half of users. This decreased blood supply can lead to brain atrophy and enlarged ventricles, which means actual loss of brain tissue over time. Alongside this, users face an increased risk of strokes, both obstructive and hemorrhagic, including small microstrokes and major central nervous system damage. Another critical concern is seizures. Cocaine lowers the brain's seizure threshold, making both initial and recurrent seizures more likely through what's known as kindling, a process where repeated seizures cause the brain to become more excitable and sensitive. Cognitive functions also take a major hit. Chronic cocaine misuse impairs verbal learning, memory, and attention, and unfortunately, these deficits can persist for months even after users stop taking the drug. Finally, cocaine use is closely linked to the development of psychosis and mood disorders such as anxiety and depression. These emotional disturbances can arise during active use or linger afterward, highlighting the drug's extensive impact on mental health as well as neurological function. The brain MRI images here really emphasize the physical changes happening inside the brain, helping us grasp the severity of these neurological and cognitive effects. Here we focus on the risks associated with using cocaine in combination with other substances. The pie chart clearly shows that the highest overdose risk comes from mixing cocaine with opioids, accounting for 40% of the relative overdose risk. This combination, often called speedballing, is especially dangerous because the opioids suppress breathing while the cocaine acts as a stimulant, creating a deadly interaction. Next, combining cocaine with alcohol contributes to 35% of the overdose risk. This mixture produces a toxic compound called coca, which stays in the body longer and significantly increases heart toxicity. Lastly, using cocaine alone still carries a significant risk, representing 25% of overdoses. Beyond these, mixing cocaine with other medications like antihistamines or antidepressants can also lead to fatal outcomes. This data highlights how dangerous polydrug use is and why it is crucial to be aware of these interactions to prevent overdoses. Here, we see the typical progression of symptoms during cocaine withdrawal. Initially, within hours after the last dose, individuals experience what's called the acute crash. This phase is characterized by deep depression, sometimes accompanied by suicidal thoughts, as well as fatigue and excessive sleepiness. Following that, during early abstinence, which can last days to weeks, vivid dreams become common, along with sleep disturbances like insomnia or hypersomnia and persistent fatigue. Finally, the extended recovery phase can take weeks or even months. Cognitive difficulties and poor sleep quality often linger during this time, and these issues are strongly linked to the risk of relapse. Understanding this timeline is crucial for providing effective support and intervention throughout the withdrawal process. Here we have the DSM-5-TR classification of cocaine use disorder, which falls under the broader category of central nervous system stimulants. The first category, stimulant use disorder, refers to persistent misuse that causes significant impairment, including factors like tolerance, withdrawal symptoms, and related harm. Next is stimulant intoxication, which describes the immediate effects after using cocaine, such as increased energy, but also potential hazards. Then we have stimulant withdrawal, which involves symptoms like depression and fatigue that occur when use stops. Stimulant-induced mental disorders are psychiatric symptoms caused specifically by stimulant misuse and require clinical attention. Finally, there's the unspecified stimulant-related disorder, which applies when use causes impairment but the full criteria for a specific disorder aren't met. It's critical for clinicians to distinguish these stimulant-induced symptoms from primary psychiatric conditions to ensure proper diagnosis and treatment. The diagnosis of stimulant use disorder itself is based on meeting at least 2 of 11 criteria within a year, and severity is rated from mild to severe depending on how much the disorder impacts the individual's life. Additionally, remission status is tracked to reflect progress in recovery. Let's take a closer look at the entire process of illicit cocaine production and trafficking. It all begins with cultivation and harvesting, where coca leaves are picked every 3 to 4 months and dried under the sun. This step is crucial as it sets the foundation for all subsequent processing. Next, the dried leaves undergo initial processing locally, where they're mixed with water and sulfuric acid in plastic-lined pits to create cocaine base. This chemical treatment marks a key transformation in the production chain. Following this, the cocaine base is further refined using various chemicals to produce cocaine hydrochloride powder, the form commonly seen on the streets. This stage is essential to create the powder that's then packaged. The packaging and distribution phase involves finishing the powder into consumer-ready products, which are passed through multiple dealers until reaching markets. Looking at the scale and trends, cultivation increased steadily from 2013 to 2017 before experiencing a slight decline by 2019. Nevertheless, production efficiency has been improving, meaning more output is generated from less raw material over time. Finally, it's important to consider the risk factors involved. The drug is frequently adulterated multiple times during distribution, raising the chances of overdose and exposing users to harmful contaminants. This ongoing issue adds a serious health dimension to the trafficking problem. Cocaine misuse has far-reaching social and health consequences that extend beyond individual users. One of the most alarming trends is the increase in overdose deaths, frequently involving a dangerous combination with opioids. This often leads to critical emergencies like severe cardiac and neurological complications, which is why emergency responders are so frequently called into action, as shown in the image here. Young adults between 18 and 25 are disproportionately impacted, with males being more likely to misuse cocaine. Beyond health, the societal effects are significant. Rising crime rates, family disruptions, and heavy burdens on healthcare systems all stem from this issue. Adding to the concern is the growing availability of synthetic cocaine analogs, which could potentially escalate these harms even further in the near future. To summarize, cocaine poses significant risks, especially due to its rapid reinforcement and serious impacts on both the cardiovascular system and the central nervous system. Clinically, it's crucial to screen individuals carefully, manage the risks associated with polydrug use, and closely monitor for any cardiac or neurologic symptoms. From a public health perspective, prevention and harm reduction strategies are key, alongside ongoing research into synthetic cathinones and evolving trafficking trends. Ultimately, addressing the harms caused by cocaine requires a coordinated effort that brings together clinical care, public health initiatives, and policy responses. Continued surveillance and targeted interventions will be essential to making meaningful progress.